Thank you. Good morning. I think it's 11 o'clock and time to start. What day is this? What is my name?
The meeting's over.
Good morning. I'll start again. It's 10 o'clock and it's time to begin our Vaccra March meeting. And thank you all for coming. We're glad that you're here, and we are live streaming this meeting. This is the second Ask and Learn session that Vaccra has sponsored for the residents of Cedarfield. We are sponsoring these programs for the purpose of providing information and clarification on topics important to not only our members, but to all residents. As in all programs, we encourage you to ask questions, make comments. If you have ideas for future Ask and Learn programs, let us know. We want to meet your needs in developing a lineup of programs. Currently, we have 107 members of Vaccra here in the Cedarfield community. We're growing. If you want to know more about us, who we are, what we stand for, why we exist, you can talk with Barbara, Sally, Martha Cole, or me, and we have plenty of printed information. We're going to put a sign-up sheet in the back if you want any of that printed information that describes us and what we're about. We'll give it to you in your box. The program today is on Medicare and the Medicare Certified Beds that are planned for our healthcare area. Our speaker is Dr. Marianne Johnson. Marianne grew up in Northern Virginia. She went to undergrad at George Mason and on to the Medical College of Virginia. You remember that? Now, VCU. It took me years to say VCU instead of the Medical College of Virginia. She was in private practice in Richmond with Family Physicians Limited. She worked in the Hanover County Health Department doing prenatal care, internal medicine, and pediatrics. Marianne also volunteered at Goochland Cares and served on the Pharmacy and Therapeutic Committee for Medicaid for the state of Virginia. She and her husband moved to Cedarfield in 2018. He passed away in 2021. They were married almost 50 years. They have 2 sons in the area, and as Marianne describes them, she has 4 wonderful grandsons. Marianne.
Thank you. I better correct that I have 1 daughter and 1 son, because it never gets out that Lisa was a boy. I might be cremated or something. Thank you for having me. Medicare is a pretty broad subject matter. I have some of the basic principles here, and I will address what a certified Medicare bed is. If anybody is going to take anything away from this, I'm going to give 3 points initially. One is Medicare does not pay for long-term or custodial care in a nursing home. That's a different scenario than somebody that is in rehab, but there are many people that are under the assumption that if we have Medicare beds here, that Medicare will pick up everything. It does no custodial or long-term care. The second one is there are many, many options. Everybody gets Medicare A and B, which I will explain. Most people have to have some supplement, and there's 2 ways to do that, which I will discuss later. One is through an independent contract that you have with an insurance company as a secondary, and another is through what is called Plan C through Medicare. As everyone knows, Medicare is an insurance. It's sponsored by the federal government that most people over 65 have. It is intended to cover medical services. There are some exceptions. Some people with kidney disease and other disabilities may have Medicare at an earlier age due to their medical condition. The two plans are basically the original Medicare, which is what you had a supplement, you had a prescription drug card, and Medicare typically picks up 80% of any fees from the hospital or the physicians, and your supplement usually covers the rest. The second one is called Medicare Advantage, which is set up on what we call an HMO, which is a health maintenance organization, or a PPO, which is a preferred provider system. They cover some other services that are not covered with the original setup. They oftentimes covers pharmacies, and they have other services available. One of the things with that was an HMO, you are oftentimes restricted to a primary care in a certain network, and you need referrals for some of the HMOs to see specialists. On the PPO, you do not have to have a primary care in the PPO, but you may need to have the primary care specialists that are in the preferred list. And sometimes they do need referrals, and sometimes you do not. I know everybody's seen things for Medicare Advantage on TV because they're flooded with them. And today, by chance, we do thank you to Align Senior Health, which has a contract with Cedarfield. We have some representatives from there that will be in the back that can address any specific questions you may have if I don't address them here. And they also have, which are called, some of the Plan Cs have what are called special needs facilities, so that they do cover some ancillary services for people that are in memory care or in health care that the traditional Medicare with a secondary does not cover. Now, exactly what does Medicare cover? Part A is inpatient hospital services. It will cover a skilled nursing care facility, which is considered a facility that temporarily can get somebody back on their feet. And while they are in there, things like physical therapy, occupational therapy are covered. And they will cover any skilled nursing care needs, such as dressing changes and IV medications, depending on the facility, and feeding tubes and things like that. They also cover some nursing care services in healthcare that are considered skilled care. But that is only the particular service. So if somebody needed a dressing change, someone would come in and do that. They do not cover what Medicare considers custodial services, or like a room, a bed, baths, sheets, your food, moving from one location to the other, transferring out of a bed to a toilet or into a wheelchair. They do cover, Part A covers all of hospice, and in hospice they cover the drugs. And they will cover home health care for someone who has gone home after a hospital stay that might need some home health or physical therapy. Part B is more of the outpatient coverage. It will cover what you do when you go to the doctor. If you go to the doctor with a sore throat, it will cover that. It will cover the labs that are done. It will cover any outpatient testing that if your physician says, I really want to get an MRI, it will cover that. It covers outpatient care if somebody is going to physical therapy or to occupational therapy or to speech therapy. It also covers durable medical goods, so walkers, crutches, bedside commodes, hospital beds at home, and various and sundries. And the biggest thing it covers is all preventative care. So I'm sure everybody's aware of what the Medicare wellness exam is. You have 1,000 questions to answer, and they go through a little short memory status test, and there's a certain amount of blood work that can be done in order to keep everybody as healthy as they can possibly be. And all that and all the lab work are covered under your Part B coverage. Medicare historically, just plain original Medicare, does not cover prescriptions. There are a few exceptions when it comes to certain diseases, but for the most part it doesn't. So most people have what is known as Part D. And Part D is what you have for prescription coverage. And most of you probably have a prescription plan. So that is what is used when you go to the pharmacy to buy your medicines and they say your copay is $10, $15, $25. Unfortunately, for some of the newer medicines that are very expensive, your copay can be quite higher than that. Many of the Part C Medicare Advantage programs have prescription coverage included in them. When it comes to prescription coverage, there's also something known by Medicare as the donut hole. Medicare will allot a certain amount of money for a person, and when that allotted amount runs out, then you will hear people say, I had my prescription coverage through November, but I have to pay for the month of December out of pocket for what it is. And this mainly happens with people that are on multiple very high-priced drugs that they price out of the system, and then for that 1 month, they would be responsible as a self-pay patient for those medications. And then in January 1, Medicare would start, their prescription plan would start picking them up again. So that's sort of the basics on Medicare. Now in Medicare, there's so many plans, either with independent insurance companies and independent pharmacy coverages and doing Part C. It behooves you to look at the plans and talk to people that represent them, because what you have today may be perfect for you today, but what you may need tomorrow or 5 years down the pike or 10 years down the pike may not be perfect. So it's very important that you reassess this on a regular basis, because things change and things happen, to see what is the best plan that meets your needs at that time, rather than finding out about it after the fact. So part of today with Align Health here is to give you some ideas of what is actually available other than what we've been all doing for the last 20 years. Now the big question here, I guess, is what is a Medicare certified facility? A Medicare certified facility is one that Medicare has come to, and they meet a criteria that they has been set by Medicare, and they are certified by Medicare that they have everything in place that Medicare wants. It involves staffing, it involves how wide the doors are in the room, it involves the quality of the food. It's about 23 pages long. Once they get that, then it is primarily going to be used for what they call skilled nursing, which is rehab. These are the people that are not going to be here long term. Typically, a rehab stay is about 20 to 21 days for most people. And the way it has been situated by Medicare is that Medicare, if they are certified, Medicare Part A will pick up to day 20. After day 20, from day 21 to day 100, there is this copay for the patient. Most of these copays are then covered by their secondary insurance. At day 101 is considered to be the end of a rehab period. And at that point, if there's been no success and there's been no progress, a patient will be placed into long-term care, which is 100% paid for by the patient. So I had a meeting with Paul Gregg last week, we talked about this. So there's a lot of concern that we're going to run out of beds here at Cedarfield. The plan that has been in place and all the other Pinnacle living homes that have this in Williamsburg and in Northern Virginia is there are always 2 or 3 beds that are empty. There's a great communication when somebody goes into the hospital through the social service people's on the floor and the center they came from with what is the patient in for, how long do we think the patient is going to be there, how is the patient proceeding. And that usually occurs daily. So Cedarfield will have a pretty good idea that Mr. Jones is in the hospital and he's got sepsis, and they're thinking that, he's doing really, really well, so we should be out in 3 or 4 more days. So that the center he's going back to for rehab or continuation of IV antibiotics will know that they have to hold a bed for Mr. Jones. With doing that, that means there's still 2 or 3 other beds that are available. But rehab is fluid. So rehab has people that they may have 2 discharges that day, and that means they have 5 beds available. And if there is a superfluity of beds and there is a Medicare person in the hospital that needs rehab and Cedarfield has 5 or 6 empty beds, they will take a non-Cedarfield resident to fill up 1 or 2 of those beds, still leaving a reserve of their 2 to 3 beds for Cedarfield residents. Now, if this person that comes into rehabs out in 21 days, or before, that bed is then cleaned, it's open again. If it is a situation that this person is making no progress, we are exactly the way we were, or very minimal improvement from when they were discharged from the hospital, they are then a long-term care. That is an entirely different process, and they will not be long-term care at Cedarfield. At that point, there'll be social services and people working with them and looking at other institutions of their choice for nursing home. Because when you go into long-term care, it will depend on your finances, it will depend on what you can afford, and all those forms and all that information is presented to the nursing home for them to make a decision if they can take this patient into their center. There are in the state of Virginia multiple Medicare, Medicaid nursing home beds throughout the entire Richmond area. So if someone just doesn't have the income and the resources and they qualify for that, they will be transferred to the first Medicare, Medicaid bed that is available, or the first place that their family says, this is the closest one to my house, I really want to go to Our Lady of Hope, or Lakewood Manors, right across the street, or something like that. Cedarfield will occasionally, from the community, if there is a superfluity of long-term care beds take someone from their home. But what they have to do is the same thing everybody here had to do to apply to Cedarfield. They have all their finances, everything's up front, they do the whole 9 yards. They will be admitted directly to health care, and they will obviously not be able to have life care services. So one of the other big questions I've had is, how does this impact with people that are life care? Well, people that are in rehab right now that are Cedarfield residents that have life care are up there, and they're paying their monthly fee that they have paid all along. Because we are not Medicare certified, the services they are getting as far as physical therapy and occupational therapy or speech therapy are all being billed right now through the outpatient service, which they are going through Medicare B. If they're Medicare certified, everything will be going for Medicare A. And then the entire fee for being up in healthcare and all the ancilleries is paid for by Medicare in full for the first 20 days, and then between your secondary and Medicare for up to the next to day 100. The question that has been asked, and I asked it, is where are these funds going? And I did not get a direct answer. It has not yet been established. If these funds are going to go back into healthcare, if they're going to go in the general operating budget, I have no earthly idea what they're going to do with them at that point. So that's where it stands for Cedarfield. How they plan to work it is they have 3 pods of 20 beds, and right now rehab and nursing and long-term nursing care are mixed in among those areas. What they hope to do is to get 20 beds certified, and then they will bring in rehab patients, and then if that pod is full, if somebody else is coming from the hospital that needs a rehab bed, someone will be transferred out of that group of 20 beds into another family unit, so that eventually the 20 certified Medicare beds will be primarily rehab patients. That is not to say if somebody in Cedarfield that's a life resident needs a long-term care bed, they cannot use one of those beds till one opens up in the pod, but they will come in as long-term care. They will not come in as a rehab patient. Now, there's also a caveat in this. Most people that are even Cedarfield long-term residents that come back are considered somewhat rehab patients, because there's always something that needs to be done. So lots of times Medicare will pick up a portion of the first month back for someone that has been in long-term care for services, because they might be getting other ancillary care to help them again relearn how to transfer, or to relearn how to feed themselves, or to have therapy because now they're coming back with a stroke. And that's highly individualized. And Medicare does have the right after 30 days to assess and decide if they are going to continue those services. If a person is making progress and all the reports say, Mr. Jones is just doing fantastic, but we really think we can get him up to 90% if we have another 2 weeks, most likely Medicare will approve that. If after they assess it 21 days to 30 days, they go and we have gone nowhere. Nothing has changed. We are exactly like we were the day they came in. that person would then immediately be transferred to what is considered a long-term care status, because you're sort of flogging the dead horse. And in that, I will mention, and the people in the back can do this probably far better than I, but under some of the Plan Cs, there are ancillary services for people that are in healthcare and in memory care. There's a lot of care planning, there's access to nurse practitioners to come out if someone is sick, and services if you need dental care, helping orchestrate appointments that might be needed, or orchestrating that some of these appointments can be done on site. And they're much more qualified in doing this because this is what they do every day. The way it usually works in a nursing home from a physician standpoint is there's usually medical directors of the nursing home, and they are on staff, and they often do, every 60 days, Medicare requires that every Medicare resident have a complete physical exam. And it covers everything. And they are then recertified because they may need to have ancillary services. But from day to day, when you have patients that you would listed as the doctor in a nursing home, you may get the call, you know, we really think Mr. Jones has a urinary tract infection. So you go, okay, well, I need this, and I need this, and I need this, and call me back with the results. So the results come back, and you go, okay, we're going to start him on this antibiotic. And then you sit and you wait. So that might not be the most ideal. You don't run to a nursing home necessarily to know what you're going for. And then most of the time, those people, if they get better, that's fine. If they're getting worse, will then be, oh, we now have a fever of 102, and we're going to they're sent to the ER to decide if they need to be admitted. The advantage of having more of a clinician or nurse practitioner on staff is, and the whole point of this is, you know, maybe if Mr. Jones really isn't feeling well and somebody comes and looks at him on Tuesday and gets some lab work and really takes looks and said, you know, I think this is what's going on, let's go ahead and be a little more aggressive about this. Mr. Jones might be able to get better where he is and avoid being transferred to a hospital, avoid a hospitalization and coming back. So with having more preventative services and more services available in the nursing home, through some of these policies, you indeed may be reducing inpatient hospitalization. And anyone over the age of 65 to 70, although we think we're very young, they have a much harder time with infections and pneumonia and congestive heart failure and things like that than somebody that's 35 or 38 or 40, or even somebody that's young that has a congenital heart problem that's lived with us all their life. So the sooner you can jump on things from a medical perspective, the better off you are. This is also a service that will then talk to family members and keep everybody in the loop as what's going, because your daughter may be in Delaware and your son might be on a business trip, and here you are all by yourself. So that's kind of the take on where some of this stuff is coming and what is available. Right now, the secondary coverages that we have with original Medicare are not covering. They will cover ancillary services, but they're not covering some of the preventive stuff. They'll cover anything a doctor orders and anything from PT and OT and lab work, but they don't necessarily have a provider coming in to actually look at somebody. So that can be a benefit for those people that are in healthcare or have loved ones in healthcare. So that's basically what Medicare will cover, and it's basically designed to be for hospital and physician coverages. It's not designed to be what there is known as long-term care services, and that's why many people are here with life care. That's why many people have independent long-term care insurance policies, which are written by insurance companies to cover so much per day, depending on your policy, and depending on if you have a cap to help abate some of the expense in long-term care. And so that's the plan at Cedarfield right now, and that's what they're hoping to do. The big hang-up right now for Cedarfield is going to be staffing, because all across the nation, all the nursing homes and the hospitals and the doctor's offices, we don't have the staff. And so they have to have a staff, and they have to have so many nurses for so many patients, or CNAs for so many patients, and that's going to be the hardest leg of this whole thing to fill. And hopefully with time that will turn around, but everybody is having a hard time recruiting staff and keeping staff. The other thing, I did have a question that asked if Medicare would run out of money. I think not. The feds have always been available and come up with the ante to keep it going. But there is a very interesting fact. 80 to 90% of the Medicare budget goes to end-of-life care. So one thing that you can think about your children coming up, like, will this program be here when they're 70, is that a lot of people have gone to their lawyer and they have a DNR, which is do not resuscitate, which means if your heart stops or you start breathing, they're not going to resuscitate you. An advance directive, which you can talk to your family doctors about it, is a little more specific, and it gives parameters that you've talked with your family about, you've talked with your spouse about what your wishes really, really are. So if you arrive at the hospital and you've had a horrible stroke and you're totally unresponsive and they do all the tests they need to do in the ER, and the ER doctor says to the family, there's a 2% chance that they're going to make it. You have now put a son, a daughter, a cousin, a niece, or whatever in the of looking at this thing going, well, she doesn't want to be resuscitated when her heart stops, but her heart's beating fine. So that person will go in and they will do everything that they can do to try to keep them alive, even though they may not be viable as you knew them before this catastrophic event. When you look at your advance directives, you have a say in that while you're still alive. When nobody's sick, when nobody's under pressure, you can sit there and say, hey, look, if I go in there and that's what they tell me, really, I've lived my life, I've been there, I want comfort care. Just make sure I'm comfortable and let nature take its course. I don't want IV fluids, I don't want tube feedings, I just want to be comfortable. Just let me go to sleep and, 2 or 3, 4 days a week, 2 weeks or whatever, that would be my death. If you're in an ER and you've set an advance directive, the doc said, that it's 70-30. 70% they're not going to make it, but 30%, they're healthy for their age, they don't have any major medical problems, they could pull through. Well, you can say, to leave it a directive that said, I want them to do everything. I want them to do it for 2 weeks or 3 weeks. But if I haven't gone anywhere, then I want to convert to comfort care. And then let nature take its course. And a third option is that you go in there and the doctor said, 80% they're going to make it through this. It might be a little rough road for the first week or 10 days, but they're going to make it through this. Then you can sit there and say, pull out all the stops. I want everything done. You name it, you need to do it, do it. But let's say after 4 weeks, things really haven't improved, you can backtrack, or your family can backtrack and say, I think we've done this long enough, we're not going anywhere. Let's continue this for 1 more week, and if there's nothing, then we want to go to comfort care. So that's a little bit of a difference, which when you look at what Medicare is paying, since 90% of the Medicare budget is going to people that have not done advance directives, that a big saving, while Medicare is trying to find ways to save money with some pilot programs that are still under study so that they will still be up and viable, that's something that you can do, and you can do it and there are counselors and people that will talk you through all this and make a decision that's fairly specific, which would save quite a bit of money for Medicare. But that's a whole aside for that. But so that's kind of where Medicare is. There's a lot of stuff on the Hill and in the state legislations about what to do for prescription coverages. That really doesn't fall under Medicare, but they're trying to do something for some of the newer drugs that are very, very expensive and things like insulin to get them into a more appropriate price range. But that's all pending legislation to see what they can do with the pharmaceutical companies. Now, does anybody have any questions? There is a mic they can pass around. Did I cover everything that well?
I'm under original Medicare, and I hear that they're going to automatically change it sometime from automatic to
I have heard nothing that there'll be any change. Have you heard they're going to change the original? I've heard nothing that the original Medicare that most of us probably have, which is the plan A and B, and then we've gone out and got a secondary insurance and a pharmacy coverage. there's nothing that's been anywhere that is going to be changed at all.
So they're not going to automatically change it to Medicare Advantage?
Pardon me?
So they're not going to change people to automatic Medicare Advantage?
No, that is a choice. And that's one thing I think that people don't realize. All your secondary plans, such as the insurance plans that you contract with as secondary coverage, and your prescription plans, as well as signing up for the Medicare Advantage, which is Plan C, they're somewhat fluid in that your situation today might be that you're fine, but 6 months down the road, you might have some diagnosis that one plan will fit you better than the other. So just because you sign up for original Medicare, there's no reason why you cannot change if the whole situation changes to something that's better. Some people once a year meet with the brokers or with the people that do the secondary plans, the Plan Cs, as well as your independent plan, and go over, now I'm on this medicine, this medicine, this medicine, and this medicine, and my pharmacy bill and what I have now is outrageous. Well, they'll kind of put all these numbers in, and they are some of them, the ones with the independent plans are insurance brokers that kind of go, well, this Cigna plan, if you go to the Cigna pharmacy plan, that'll reduce your co-pays by $100 a month, or if you do this, this has got a better coverage on what you are than that. And the same thing goes if you are one plan and circumstances change, or if your spouse, and you and your spouse do not have to be in the same plans, that what is offered under a different plan, be it independent or be it Plan C, really fits your needs, and it's much more accommodating to what is going on with you physically at that time. There's no reason why you can't change. The only stipulation might be in some of them, but some of them it is not, is that you have to do it during open enrollment for some of the changes. Like right now, if you want to change your pharmacy coverage from, you have AARP and you want to go to Anthem, you would probably have to wait until an open enrollment. But I think for some of the Plan Cs, for the people in the nursing homes, they can do it quickly. Isn't that right? You don't have to wait for an open enrollment. So if you've noticed that your pharmacy coverage is going up, there are people like Active Medicare Solutions that can go in and look at the plans and go, for $4 more a month, we can put you with this pharmacy plan that covers, $75 of this prescription that you're taking, rather than the $20 that your current plan covers and to pick up. So you probably ought to reassess those things every couple of years, because we're not static. Very few people are on the same medication and nothing's added or taken away, for 30, 40, 50 years. Yes? Oh, I guess I'd give you a mic.
Okay, all right. If you go into a Medicare or Advantage plan, and then that plan disappears, or for some reason.
Well, now, I'm not the insurance people.
No, but wait. This is a general thing. Wait. But if I dealt with somebody, and okay, she was in an Advantage plan, and let's just say you think you want to change it. Well, when you go on Medicare originally, they don't look at your health. But if you are in an Advantage plan, don't they look at your health, and then some will deny you, they won't take you?
No, I don't think that. We have people that do that. They're in the back. This is Madison Cardell. She does this, and Jamie Kai is back there. Also, they may be able to address some of those questions. There, you can come up here. We can share the mic. Can address some of those, because this is what they do day in and day out. I don't write insurance policies, and I don't even know what they pay for. I just order the test.
Thanks, Marianne. Hi. So the question was, if your Medicare Advantage plan goes away and then you need to find a new one, Medicare Advantage aren't allowed to do medical underwriting, but a supplement would be able to say you're 75, you're looking for a new supplement, that's the secondary one. But Medicare Advantage are not allowed to do any medical testing before you're admitted. They will accept everybody if they qualify.
Well, I had an experience with a friend, and they would not all take her. Her Advantage plan went away, and she could only get a high deductible after that because they were looking at her current health plan, whereas when you originally go into Medicare, this is getting the supplemental, not Medicare.
Right, a
Okay.
supplemental would do that, but a Medicare Advantage
But
wouldn't.
supplemental, yes, but that's very important, I think, to factor in before you go into an Advantage plan.
Yeah, they're two different things, but we're happy to talk about it individually if you guys want to, but that was a great question.
And I also, there are multiple companies that run Plan C also.
Oh, yeah.
Yeah.
I think to add on to that, take my mask off so you all can hear me. The options vary by county. So, I would encourage you all, if you are, taking a look at what you're on and, want to learn more about what's out there. There's a great resource that Medicare provides called the Medicare Plan Finder. You put the county in, so Henrico County, and it'll give you all the options available in the county. It does vary. So, supplements, they supplement original Medicare. So, you're going to have your original Medicare, and then your copays, as Dr. Johnson said, are covered by your supplement. Part C or Medicare Advantage is delivered in a little bit different way. A Part C, they actually deliver your Medicare benefit for you. So you maintain your A and B, but they're delivering it through their program. So like ours are for special populations. So, you have to be at a nursing home level of care or have a diagnosis of dementia to join the programs that our company represents. Others, under like a chronic conditions Medicare Advantage plan, you may have to be, an ESRD, an end-stage renal, patient to join. So there's certain things out there that are newer products that are coming out year over year where there may be qualifying conditions. And in the past, certain conditions were limited from joining certain products just based on the Medicare benefits available. And then there's, obviously service area and some other conditions. But everything I would think as you look around, I would encourage everyone to take a look at that Medicare Plan Finder, what's available in Henrico County. And as Dr. Johnson said, there's independent brokers that may represent multiple products, so they're a great place to learn about the various offerings. And then specialty programs like ours where we're representing just, a very certain set of products at, deliberate sites. We use a model called captive agents. So we employ all of our agents directly. So you may have to check in and around to learn more, about each product through different means.
If you're considering changing your Medicare plan, we're out of the program. We're out of the sign-up time right now,
I
correct?
think, yes, I think they're just getting ready to start up to open. It's through December 7th, because that's my birthday, so I always remember that's the last closing day, but it's several months that it's available. I think that has to be done in an open enrollment.
The general Medicare period is October 15th through December 7th, so that's where everybody gets the big marketing where you're getting the mail and hearing the ads. And then some of the specialty programs like ours are available throughout the year. So you could pick up a program like a special needs Medicare program if you meet the qualifying conditions. And Medicare does that because you may become a nursing home, resident off cycle of that one election period. And then there are other special qualifying events. Like as you mentioned, someone may lose their benefits. One reason that may happen is because you move. So these programs are delivered again at the county level. And if you move states or move counties, your program might not be available. And one of the nice things that Medicare does with regards to the Medicare Advantage products and the standalone Part D plans is they offer you a special election period where you can go look at the Medicare Plan Finder or consult a broker and they may be able to get you on those products off cycle, even the general plans outside of that one marketing and election period in the fall.
Well, if you go to that Medicare Pathfinder or whatever you just said, what are the odds that you actually can sit down and talk to a person for an explanation?
Yeah, so most consultations, if you want to look at any different company, are free. So you can go in just expecting not to pay anything to just get an opinion. But you would click which ones you were interested in. So they would price it out for you by what medications you're on, what county you're in. They'd show you all the options. You could select a few to compare. Then you call the number for that specific company. If you'd like to do it that way, brokers, like the people right up the road next to Grapevine, the active Medicare folks, they would represent all of the different ones. And I can't speak to if that costs money, but I would suggest trying to do it online. And if one really piqued your interest, you just call the phone number that's on the website. There have very long call center hours. They're like regular time. So you'd catch somebody for sure.
And then,
Well, I think that's the issue with people our age. Number one, using the computer. Number two, understanding what the computer is saying. And then trying to figure out who you're supposed to call.
Yeah.
That's why I asked about in-person
so
consultations.
you are limited, I think, on the in-person consultations to having to go out and proactively kind of source what you want. But there are some actually state and federal level, there's a call line for Medicare. So there is an opportunity to talk to a Medicare representative over the phone. I believe the number's listed on that same website. And Virginia has, it's called the SHIP program. I think it's SHIPP. I think it's Seniors Health Insurance. I don't know what the P's stand for off the top of my head, but it's a state-funded, agnostic resource to help folks locate, options in their area. So there's some things through the government that are agnostic if you wanted to go that route on learning more.
Thank you.
Marianne, I want to go back to you. The 20 beds, that doesn't add to our license, does it? It's just part of our license.
Yeah,
what I want to make clear is, if we have 20 Medicare beds that are coming and they're going to be strictly for rehab, how does that affect the rest of the beds that are available for long-term care?
Were you here at the beginning of the talk?
Say again?
Were you here at the beginning of the talk?
Yeah, but I didn't pay.
Okay, so the way it works is Cedarfield has 60 beds.
That's right.
They are trying to congregate all of the rehab people into the 20 certified beds because the nursing care and the needs of the rehab people are completely different than the needs of the long-term care people. However, if they have no beds in long-term care and somebody from Cedarfield needs long-term care, they can go into one of the 20 beds if there's beds available in that pod, and then, but Medicare doesn't pay for it, and then they're still paying out of pocket, and then when a bed becomes available in one of the other pods, they would be the first person transferred in. So just because those 20 beds are designated that they are rehab beds, they do not have to be just used for rehab beds.
Okay, that's all I want to be clear of. Here you go, Phyllis.
I had a question. We have three people sitting to your right, standing, and they're very knowledgeable. I'd like to know what they do and what companies they represent.
Sure. Actually, Cedarfield has a contract and has had a contract with their company. This is mainly for the nursing home population, the dementia and the nursing home beds, and has a contract with them. Go ahead.
Awesome. My name's Madison, by the way. We were very familiar with Cedarfield as Jamie's grandparents lived here. But we represent Align Senior Care, which is specifically for the folks with dementia and the folks in your health department, healthcare side. So that's what we do. It's a special needs plan that Cedarfield has a contract with already. And we bring in those extra services, kind of like Marianne was talking about. If you had a UTI, we would bring in the nurse practitioner. We would coordinate those visits and make calls to your family member, kind of that extra level that traditional Medicare kind of expects you to do on your own. But this is Align Senior Care, so we can talk to you about that.
All three of you are
All three of us. And this is Josh.
You're not Medicare consultants, you are service providers.
Yes.
Thank you.
We're also licensed with the state of Virginia as health insurance brokers. So it's a regular licensing period, just like other professions, like a real estate agent. So we have to be knowledgeable to a certain level on every product available. Josh, Madison, and I are all licensed. So we're happy to weigh in on some general Medicare coverage questions. And I think if Dr. Johnson, wants to become an insurance agent in a second career, we're located over at Knuckles and Cox, and we'd be happy to have her.
I'm sticking with patient care.
I don't know whether it's a question or comment. My head is spinning right now. There's so many changes in the wind. Is it on? Okay.
A question on what?
When I came to Cedarfield about 8 years ago, we had a dementia floor, 3 healthcare. We had healthcare, but had north, central, and south, basically 3 units. And we had assisted living. Now today we've got a healthcare dementia unit, and we're going to have this Medicare unit you're talking about. Now this basically takes up the 2 new wings we built. I think we're fine. My main concern, what I'm trying to get to, I think money is getting in the picture pretty thick. If I understand where we're headed with this Medicare wing, it really would be wonderful for the residents of Cedarfield when they're coming from the hospital for a limited time. But I know, and you know, as this gets involved and we get involved with Medicare, it's going to be when the public finds out that they can pay those extra fees and come here for that care. We're going to sell those beds, I'm sure. Just like we do in the dementia unit. And I'm coming to what my main concern is. My wife has been in the dementia unit and she's now in healthcare dementia unit. But when they go to, my main concern is we are an aging population here at Cedarfield. And when I came, I was assured when I came under continuing care, and that covers many of you here today, that I was guaranteed when I left independent living, I'd go to assisted living, I'd go to health care, and it would be immediately available. That is not the case today. And as we go outside bringing in people, and I know it's for money, our problem is going to get worse, and that's my challenge to management. Now, I heard Paul explain this. If we've got 5 or 6 beds available, that's one thing. But I want to challenge management that they always reserve at least 2 beds in these units. The other concern, and Matt Damon expressed this one day, meeting with us, but it never happened, that they would do a better job of screening these people coming in from the outside. I saw it happen many times in the dementia unit. True, the people paid big dollars to pay to come there for their loved ones. But most of them were in desperate situations, and it took 2 people to take care of them. And in several cases, they had to ask them to leave. When we bring in people from the outside, we need to make sure that we know more about that individual. We've been very short of staff, and it broke my heart when I saw how short we were during this pandemic, that we had outsiders that were brought in that paid the big dollars, and it used up so much of the resource caring for them. And there lies my concern. I think all these changes we are making is for the benefit. But we need to never forget that those of us that pay the money to come here, that we are always first. And I'm worried sometimes that we're looking more about dollars. And it scares me. I'm sorry.
That's really not in my scope. I'm just sort of talking about Medicare and what's advantaged through that. I think that's something that has to be directed through other avenues. either through the Residents Council or through Vaccra, but I have.
But it will create more outside interest coming in here for those services.
It really depends on the number of beds they have and if they are willing to take someone. It has been running in Williamsburg in Northern Virginia, and they have so far not had to deny a resident of that center placement in the center. I can't say something could never happen because we just had COVID where hospitals didn't have beds. So if your cardiologist was at Henrico Doctors and you were having chest pain and the rescue squad was called, Henrico Doctors didn't have a bed, so you were diverted to St. Mary's because they happen to have an ICU bed, or you were diverted to Johnson & Willis, or to St. Francis, or to Regional Memorial, and you would be taken care of by other people. Now, hypothetically, if 40 Cedarfield residents were in the hospital with COVID, and 12 of them got discharged on the same day, and there were no beds at Cedarfield, something would have to come. But that is more of the exception than the rule. I was told they were always going to make sure they had available beds.
Can I just piggyback on what Mr. Smith had to say? Because he certainly spoke to every concern I have as well. It seems to me that this is a money-making proposition, and that worries me. We are clearly having a crunch with those who provide the services in these important areas. That crunch in hiring people is not letting up, yet we're going ahead with this program. Does that mean that the people that are providing these services are going to be spread even thinner?
They're not increasing the number of beds at all. The number of beds are 60 right now, and they will remain 60. They are not putting in 20 additional beds, that they will have 80 beds.
I understand that. However, right now they can't cope with what they have.
Well, right now they're running at 57 people in healthcare, so they have 3 beds that are vacant in order to take people that are in the hospital that might be being discharged to come home. The staffing issue is a big issue everywhere right now to try to get people to do it.
And I understand that it's a big problem everywhere. So my question is, why are we making the problem, why are we exacerbating the problem at this point in time? The other thing
I don't see that they're exacerbating the problem. Usually in Medicare Certified facilities, the level of care is higher if they are not than when they are not certified, and the fact that Cedarfield is not necessarily going to increase the number of beds, and they are not going to be taking people from the hospital. They can refuse them, but if they have 6, 7, or 8 beds empty in healthcare, it behooves them to have some of them filled on a temporary basis.
You said we had 60 beds?
We have 60 beds. Right now, we might not have a total of 60 because they're renovating that one room.
We had 60 beds before we built the new health wing, and there are 40 beds in those 2 wings. And we still short of help. I tell you, we don't have the help.
They have 60 beds in health care that do not count assisted living for that.
What are these 2 wings, 4th and 5th floor, counted as?
The head of nursing said they have 60 health care beds for nursing home people and for including rehab. That does not count the assisted living and all of that.
But healthcare dementia and the other floor over there all comes under healthcare, and they don't have the help to support the system now.
Well, the head of nursing, when I talked to her yesterday, we have 60 beds.
Is that one reason that you said at the beginning, we do not yet have a certification because we do not yet have the Medicare standard of staffing?
That's probably going to be the biggest thing, just because there have been articles in the national news. This is a whole United States problem. It's true for the offices, it's true for the hospitals, it's true for the nursing homes. And hopefully it's going to resolve itself when people come back to work from COVID. A lot of people got burned out. And so the staffing issue is not a lone Cedarfield issue. It's global.
And I think we all understand that.
Dr. Johnson, I could help with it.
Okay.
Talking about a Medicare Certified Bed. So a Medicare Certified Bed, thinking back to Dr. Johnson's presentation, typically these, are paid for under your Part A benefit. That's what being Medicare Certified is. These are beds that are occupied by folks, like Dr. Johnson said, that are coming back from the hospital for short-term recovery. It is paid differently than if the bed is just a Medicare Part B bed. So it does open up funding. So, it does pay for more care, whether that be through your original Medicare benefit or like our plan. So we would pay the provider, which in this case would be Cedarfield with their Medicare certified bed license. We would pay them a different rate that's in line with the Medicare payment rate for their Medicare Part A services. So providers are paid differently for a Medicare Part A bed, and like Dr. Johnson said, Medicare Part B is covered under room and board, so like what you all are paying Cedarfield now. So it opens up the funding and allows for that short-term rehab to be funded higher. So, I'm not in a position to say how Cedarfield's going to do that, but I can tell you that the funding mechanism behind having a Medicare certified bed intended for those recovering on that short stay, there is more funding by getting the certification.
I had a quick question. Has the new facility been certified yet by Medicare? What is the anticipated date for certification, and what does it need to do?
Originally, they were hoping to have something by November. However, with the staffing shortages and the availability of help to staff, I doubt that that's going to happen.
I have a question. I'm confused about the numbers. So right now we have 60 beds, and we're aiming to have 20 Medicare certified beds. Are the 20 Medicare certified beds part of that 60?
Yes. They are taking 20 of the beds. The rehab people are occupying. The rehab people are up there already in beds that are in healthcare. So they're going to have one. They're going to try to get 20 beds certified for rehab. In the total of the 60, which will be the funding for that, it will be different because it'll be through Medicare A. And if they have a superfluity of empty beds, they are able to take in some rehab people. And rehab is short stay. Most of the rehab people are out within 20 to 21 days. So they may have Mrs. Smith, who fell and broke her hip while she was in Richmond, visiting her daughter and her grandchildren, but she needs to go somewhere for 10 days, 14 days, 20 days, so she can maneuver with the walker, she can get on and off the toilet, she can lift something to take it out of the refrigerator to cook. So she needs to, if her daughter or the family she's with cannot take care of her at home at that point. So Mrs. Smith would be a prime candidate to qualify for a rehab bed. Mrs. Smith might be here, depending on how fast she rehabs, 4 days, 5 days, 10 days, and she would be out. So they're not taking in long-term care people. They are only going to take in rehab, and they have the first right of refusal. If they want to keep so many beds empty and they know that in the hospital they have 3 people, they can say, we have no availability.
So the rehab will have additional extra help. I mean, as far as
they will have to meet all the
certifications.
certifications.
Have to make some certifications, and actually, I would have benefit. I just wanted to know if these rehab beds are going to be scattered.
No, what
they're
happens?
all in one section, right?
Let me show you. What this is the game plan. Now, that does not mean that a long-term care patient cannot be in that pod. So we're going to have. They're doing this family unit. I'm sorry, I didn't hear what she said.
Just a second. It's 11 o'clock. However, you're welcome to stay. And if Marianne and the 3 other folks can stay, can you all? Would you like to do that?
So the way it's set up, I'll call them pods. They're calling them family units, I think. So each unit has 20 beds. Ideally, because this care that someone in rehab needs is completely different than the care that someone in a straight nursing home needs, they are going to try to keep all of the rehab people in the unit in the same pod, okay? So initially, it's got to start somewhere. So they've designated pod A to be the rehab pod. And you had back surgery and you're coming back. So they're going to put you in pod A, and you're the first person back since we've been Medicare certified. And 3 weeks later, Mrs. Smith has broken her hip and she's coming. They will move a long-term care into one of the beds in the other 2 pods to put the second person in rehab. And that will continue when they start until they have the majority of the people that are there for rehab or on the same wing or pod or whatever you want to call it.
Okay, I just wanted to say for the benefit of others, I would have really benefited by having this program in place right away, because you get a different kind of care. And it's very difficult right now for healthcare to take care of rehab people. So I'm just speaking from experience right now.
I would just like to comment, being the Mrs. Smith that you referred to.
Not you.
It sounds to me like we were getting the same rooms paid for by 2 different sources. So Medicare will be paying, and the individuals who live here are paying.
Yes, and that they have not decided where the funding is going, and I'm not in the finance part of it at all, but there's also some things that you can look at. If you go into healthcare, okay, you are paying your life care fee, but they are holding your cottage or your apartment. So that is not generating extra income from them. So they can do this technically legally, and there are many of the places that do it. It is only for rehab, though. Now, if I can use you as an example, she had back surgery, and there was a question whether she was going to go to an inpatient facility and that she had the stamina to do it, like Sheltering Arms Hospital or Henrico Doctors Hospital, which has in-hospital rehab, which tends to be a little more intense than what you have at like a rehab bed in a nursing home. So, in case, for some reasons, the qualifications didn't meet, or Sheltering Arms said, she really needs 2 weeks to get a little bit stronger, then we'll be more than likely to have it. I was in the hospital room with her, she was given a list of where to go that were Medicare certified. And Westminster Canterbury was on there, Our Lady of Hope was on there, Lakewood Manor was on there. So had she chosen, she got into Sheltering Arms, so that was fine, but had she not, she could have chosen to go to Westminster Canterbury, and her bed would have been paid for, but she's still paying Cedarfield for her cottage. So I don't know what they're going to do with the extra funding, and that's something that that can be taken up in the Residents' Council, or it can be taken up through other Vaccra or whatever, because that is a pinnacle decision. Whether they're going to allot it for healthcare, whether they're going to put it in the general operating budget, whatever they're going to do with it, that's a decision they have to make.
Correct. Any other questions? Thank you for your report.
So we'll stick around if there are any individual questions.
Thank you, Marianne, and thank you all for your questions. Thank you for coming. We'll see you next month at another Ask and Learn.